mean, I think that's an important question. Thankfully, we've had the experience of using T-DXd in the metastatic setting now for a couple of years. So I'm going to imagine most people have sort of figured out what they will do when ILD potentially shows up, which is probably the most really important thing to be prepared for with using T-DXd. So, who is your pulmonary doctor or colleague and your radiologist that you can confer with? And I think once people sort of have a strategy, that's what I've always said is know how you're going to approach ILD, what you're going to do. And when you're prepared, I don't think there should be any real barrier to adopting T-DXd for our early stage patients. So I don't know if you feel differently. But
maybe, Sarah, any advice or any other comments on top of Shanu's advice for our community doctors, things about what they should be thinking about, what they could be doing, because that's not something they are used to doing in the early stage, right? We did TCHP and we did ACTHP, and monitoring was different, or toxicity profile management was different. So any practical advice that you could give our community?
Well, I think we're not used to doing imaging in the preoperative and adjuvant setting. This is a new ball game.
Yes.
And so I do think that does add a layer of complexity. I think, and we'll certainly talk about the residual disease setting, but I think there it's a little bit more complicated because assessing if something is ILD or not is not so straightforward when someone's had prior radiation.
Absolutely.
And so differing between radiation pneumonitis and T-DXd related interstitial lung disease, you could say, well, maybe something's in-field versus not in-field and try to make that distinction. And we'll do the best we can, but that is challenging. And the way you manage that is different. So you can treat through grade 1 radiation pneumonitis, but you can't treat through grade 1 T-DXd ILD, right? So, we are going to come up with these problems. I think we already in the metastatic setting, right? Someone has a viral infection. You're like, oh, is this their prior virus that's causing these ground glass changes? Is this really T-DXd? So, this is going to happen all the time. People get colds, things happen, right? And it's going to be hard. And this is the curative population. We don't really like holding therapy. We're not going to want to wait for that ground glass to go away because we get anxious when the tumor's in place, right? So I do think it's going to take a little bit of just getting used to. Again, we've been doing this in the metastatic setting, but I think the bar here is different and delays to care aren't going to be tolerated so well. So I think we're going to have to see how this
And what do you think your cadence in your practice will be for the imaging? Would you follow what the trial did or what we did in the metastatic trials? Would you think about that differently from day-to-day practical implementation of this in the early stage?
Well, I think in the adjuvant setting, the guidelines are different. So in the DB05 guidance, for example, you are supposed to get a baseline scan, make sure they don't have ILD at start. But it also depends on the timing of their radiation because you can give concurrent radiation in T-DXd. If you choose to do that, you do need to get a rebaseline post-completion of radiation. And you're supposed to get your initial scan after 6 weeks, and then you can do it every 12 weeks, right? So that is, I'm used to in the metastatic setting, I just time my restaging, every 6 to 9 weeks, and that will count for restaging and for looking for ILD. But here, again, you've got to think about these CT scan timings. And so that radiation does play a role because you got to rebaseline them. So I think you should follow the guidance, though, for what DB05 did.
And what about DB11?
So there, you should be getting scans every 6 weeks in the preoperative setting. And so that follows a little bit more in line with what I'm used to.
Right. And it's 4 doses. So
it's not too much.
It's manageable. It's really manageable.
Although it is interesting because they did do it through THP in the trial, right? And so that is something we're not used to monitoring at all.